Assessment Part 3. So far, we've touched on the vitals, we've touched on the biofilm and its relationship to health in the mouth. We've talked about the dentitions and dental caries. Now we're going to start focusing a little more on the periodontium. As a hygienist, it is our duty to help our patients with diseased periodontal and peri-implant issues to get their oral health into a state of health that can be maintained by the patient. So to accomplish this goal, the first steps need to include recognizing normal healthy tissue by clinical observation and evaluation with a periodontal probe, educating and monitoring the patient's daily oral self-care as a necessary adjunct to professional care, and finally, applying periodontal and preventative knowledge to the treatment and supervision of the patient until health is attained. All right, our learning objectives are listed here. After studying this chapter, you should be able to recognize normal periodontal tissues, list clinical features of the periodontal tissues examined during a complete periodontal examination, describe the characteristics of healthy gingiva, and compare and contrast the characteristics of gingiva in health and in disease, and describe the characteristics of healthy gingiva following periodontal surgery. As stated on the previous slide, we need to recognize normal healthy tissue and be able to differentiate it from that that is not healthy. We need to educate and monitor daily oral self-care. So at every appointment, you're going to question your patient about their daily oral health care, but we're going to learn about motivational interviewing, so it doesn't feel like you're interrogating them. Then we're going to apply periodontal and preventive care knowledge to the treatment and supervision until healing occurs. Okay, so it's important for us to understand what's what so that we can describe what we're seeing, okay? So please make some flashcards with these on it. Our clinical crown is the tooth above attachment, or it is what you see. So clinically, what do you see? Okay, this can include both crown and the root in the presence of recession or clinical attachment loss. Okay, that's CAL, clinical attachment loss. The clinical root is the part below the attachment. Okay, so that makes sense, right? If everything above the attachment is the crown, even if it's root surface, then we're going to call that the clinical crown. And then anything below the attachment, we're going to call that the clinical root. Now that is different from our anatomical crown. Our anatomical crown is the part of the tooth that's covered by enamel. So when you were discussing teeth and anatomy, you always talked about the crown of the tooth and the root of the tooth. This is it, anatomy. You learned this in your anatomy course. So it's the anatomic crown and the anatomic root. So the anatomic crown is the part that's covered by enamel, and the anatomic root is part of the tooth that's covered by cementum. Okay, so it's pretty easy. So clinical is what you see, anatomic is what you learned in anatomy. Okay? Okay, so here's what we were just talking about. The clinical crown is that part of the crown that is above the attachment. So, let me get my pen again. Here's our attachment in red, right? So anything, even though it's subgingival, anything that is above the attachment here is considered the clinical crown. So everything I have circled in red here is considered the clinical crown. So the clinical crown can really change, right? Depending on where the attachment is at, where the anatomical crown doesn't change. The anatomical crown, which I will do in blue here, I think. Okay, the anatomical crown, it doesn't matter which picture we're on here, is still going to be the tooth structure that is covered with enamel. Okay, and same with the root. All right, so here we go. All right, now the anatomical root I will put in green here, and again, anatomical, what did you learn in anatomy was the root, okay? So, so that's all in green, okay? And on the right-hand side, anything below the attachment is going to be the clinical root, okay? So hopefully that makes sense to you. If it doesn't, please let me know. Okay, here we are emphasizing it again because it is important that you understand which one is which. Okay, so let's talk about the normal periodontium. The functional unit of tissue surrounding and supporting the tooth are made up of two parts, the gingiva and the attachment apparatus. Now, we have 3 parts to our gingiva. Remember, our gingiva is part of the masticatory mucosa, so it surrounds the neck of the tooth and is attached to the teeth and the alveolar bone, okay? So it's made up of 3 parts. We have the free gingiva, the attached gingiva, and the interdental or interdental gingiva or interdental papilla. Then we have our attachment apparatus, and that includes our periodontal ligament, the cementum, and the alveolar bone. Again, I do recommend that you really get these 2 down and what is part of what, because these words can kind of start to get intermingled, okay? So our attachment apparatus has 3 parts, periodontal ligament, cementum, and alveolar bone. You need that periodontal ligament. Remember, it feeds its fingers into both the cementum and the bone to attach the tooth to the bone. So that's our attachment apparatus. Let's talk a little bit about the gingiva now. The free gingiva or the gingival margin, in health, the free gingiva is closely adapted around each tooth. This is that free gingiva that's above that free gingival groove, right? This is going to be our sulcus, help be a part of our sulcus. It connects with the attached gingiva at the free gingival groove and attaches to the tooth at the coronal portion of the junctional epithelium, the JE. Now, our free gingival groove is a shallow linear groove demarcating from the free form of the gingival margin to the attached gingiva. In health, about 1/3 of teeth may show this visible gingival groove. In the absence of inflammation and pocket formation, the gingival groove runs slightly parallel and about 0.5 to 1.5 millimeters from the gingival margin, the top of that free gingiva. The gingival groove is approximately at the level of the bottom of the gingival sulcus. Now, the sulcus is what we call that space between the free gingiva and the tooth, okay? And the base of that is the junctional epithelium, the attachment. So that's where you should see this free gingival, this gingival groove, okay? Now, in health, that area is called a sulcus, but in disease, it's called a pocket. Okay? Now, the gingival margin is just the crest or the top of the free gingiva. Okay? The gingival margin is about 0.08 to 2.1 millimeters coronal to the CEJ. That's in health. Okay? And it marks the opening to the gingival sulcus. Now, let's talk a little bit about the gingival sulcus. It is the crevice or space between the free gingiva and the tooth, as I already said. So the boundaries include the inner boundary is adjacent to the tooth surface, and this may be enamel or cementum or part of each, okay, depending on the position of that junctional epithelium, that attachment. The outer part is going to be the sulcar epithelium of the free gingiva. Then the base is the coronal margin of the attached tissues that form at the base of the pocket, okay? Now, sulcar epithelium is the continuum of the oral epithelium from the free gingiva. It is non-keratinized, and it plays a crucial role in healing of the oral environment from periodontal tissues and bacteria. The depth of the sulcus, the average histologic depth of a healthy sulcus is about 0.8 to 2.1 millimeters. Now, those are measurements we can't get, okay? So we would say 1 to 2 millimeters, okay? So the average clinical probing depth of the normal gingival sulcus is going to be 1.3 to 2.7. So we're going to say the normal depth of a sulcus is going to be 1 to 3 millimeters. Okay, we don't use 1.3 to 2.7. We will say 1 to 3 millimeters. Okay, and that's in health. Gingival crevicular fluid is, or sulcar fluid, a lot of people may refer to it as that, is kind of a serum-like fluid that seeps from the connective tissue out through the epithelial lining into the sulcus. Okay, the flow rate, and remember some medications can come out of this gingival crevicular fluid. Okay, the flow rate is slight to none in a normal healthy sulcus. Okay, the gingival crevicular flow rate reflects a change in the permeability of the tissues. So what changes the permeability of the tissues? That's going to be the epithelium, right? Is there inflammation that is allowing, that's thinner and more porous, allowing that fluid to flow into that area? It is a part of the local defense mechanism and is able to transport many substances, including endotoxins, enzymes, antibodies, and certain systemically administered drugs. Possible use as a diagnostic aid for periodontal disease activity because the composition changes in the presence of inflammation. All right, now let's talk about our JE, or our junctional epithelium. It is stratified squamous non-keratinized epithelium made up of 2 strata, so 2 layers. One is adjacent to the connective tissue, and one is facing the tooth surface. The junctional epithelium is continuous with the sulcar epithelium and completely encircles the tooth to form a tight band or seal around the tooth. The junctional epithelium cells have wider fluid-filled intracellular space that contains polymorphonuclear or PMNs, leukocytes, and monocytes that pass into the gingival sulcus to manage the constant microbial invasion and insult or challenge. The size of the JE, it may be up to 15 to 30 cells in thickness where it joins the sulcar epithelium, and then it tapers down to 1 to 3 cells in thickness at the apical end. The length ranges from a quarter to about 1.35 millimeters. So again, they're measuring these with special tools. So the position of the junctional epithelium, as the tooth erupts, the attachment is on the enamel, okay? And then during the eruption, the epithelium starts to migrate towards the cemento-enamel junction. At full eruption, the attachment is usually on the cementum where it becomes firmly attached. With wear of the tooth on the incisal or occlusal surface and with periodontal infections, the attachment then migrates along the root surface. So it doesn't come up, it's going to go down, okay? And we don't want that, right? Relation to the crest of the alveolar bone of the attached gingival tissues, the distance between the base of the attached and the of the attachment and the crest of the alveolar bone is approximately 1 to 1.5 millimeters. This distance is maintained in disease when the epithelium moves along the root surface and bone loss occurs. Okay, so as bone loss occurs, generally this junctional epithelium is going to migrate with it. All right, let's talk about the interdental gingiva. They are in health. The interdental gingiva occupies that interproximal space between two adjacent teeth that are in contact. Okay, so any two teeth that are contacting each other should have that space filled with gingiva, with the interdental papilla or interdental gingiva. The tip and lateral borders are continuous with the free gingiva, whereas other parts are attached gingiva. An interproximal area is also called an embrasure. So remember, we have many different embrasure spaces, right? Papillary height may be classified as follows, and I want you guys to know this. This is going to be on a few of your tests, probably on your boards also, okay? So please make cards with this information. So we have type 1 embrasure, and that's where the tip of the interdental papilla is under the contact of the two adjacent teeth at the most coronal aspect of the CEJ. Type 2 embrasure, the tip of the interdental papilla is apical, so below the CEJ, but coronal to the height of the facial. Embrasure 3, and we do have a picture of this coming up, but I want you guys to have this down on cards so you know what, writing it, not just typing it, writing it down, so that's like saying it 7 times when you write it down, okay? Then we have type 3 embrasure, and that's where there's complete loss of the interdental papilla due to extensive recession, all right? Now, you will have to, when you're doing your assessment, you're going to have to observe the papilla, okay? So the shape kind of varies with spacing and overlapping of teeth, and the gingiva might be flat or it might be saddle-shaped when there's spaces between teeth, or it may be tapered and narrow when the teeth are really crowded and overlapped. So between the anterior teeth, you want the interdental papilla or the interdental gingiva to be pointed or pyramidal. Okay, so like a pyramid. And then between posterior, it's going to be a little bit flatter than the anterior papilla because the teeth are wider in that contact area, right? And so it kind of flattens a little bit. So do know that there are 2 papilla. There's always one on the facial and one on the lingual. And they're connected by what's called a caul. That's C-O-L. And they're found and those are found when the teeth are in contact, okay? So you have one papilla on the facial, one on the lingual, and it's connected by this cull, which is kind of the shape of a saddle, okay? So a cull is a depression under the contact area between the lingual or palatal and facial papilla. And this conforms to the proximal contact area. The center of the cull area is not usually keratinized, and that's important for you to know. So the center of the cull is not usually keratinized, and thus is more susceptible to infection. Most periodontal infections begin in the cull area. All right, so I really want you guys to think about that and to know that. So when they say that most periodontal infections begin in the cull area, what does that tell you? Where are you going to see bleeding most likely? The bleeding should be found most likely is going to be first found interproximally, right? All right, now let's move on to our attached gingiva. The attached gingiva is continuous with the oral epithelium of the free gingiva and is covered with keratinized stratified squamous epithelium. It's keratinized, it's tough, so it's masticatory, right? The maxillary palatal gingiva is continuous with the palatal mucosa. Attached gingiva of the mandible, of the mandibular facial and lingual gingiva and the maxillary facial gingiva is the mucogingival junction, okay? So you're going to find a mucogingival junction on the maxillary facial gingiva, attached gingiva, the mandibular, lingual, and the mandibular facial. Now, if you remember this from anatomy, we're going to talk about it here, but that's where the mucosa then begins. So you have the attached gingiva and then you have the oral mucosa, and this is just that gingiva or this marking along that area. So the gingiva, the attached gingiva is firmly bound to the alveolar bone. The shape follows the depressions between the eminence of the roots. The eminence of roots, remember, those are kind of those little bumps in the bone as to make room for the roots. So you have kind of those little bumps in the bone. Those are called eminence. Okay? So it's just gonna kind of follow that. So it's not gonna be flat all the way around, right? You're gonna feel texture or little bumps in there where the roots should be. Okay, let's talk a little bit about the appearance of the mucogingival junction. The MGJ, which is what we refer to it as, appears as a line that marks the connection between the attached gingiva and the alveolar mucosa. Okay, so this is going to be down a little bit further if you're on the mandible and up a little bit further when you're on the maxilla. It's really important that you know this marking and that this is where it is, because when we're giving injections, a lot of them are going to be in this area. Okay, there's multiple reasons why you need to know it, but that's the one that came right off my head while I was talking. Okay. In the anterior, the MGJ is scalloped, but it is fairly straight in the posterior areas. A contrast can be seen between the pink of the keratinized stippled. Stippled means it's kind of like an orange peel, the little tiny bumps everywhere. Okay. The keratinized stippled attached gingiva and the more vascular alveolar mucosa that is a deeper reddish pink. So you're going to have pink, firm, stippled, this is in health, attached gingiva, and then you're going to have the reddish pink, deeper reddish pink color for the alveolar mucosa, and that's just because it is more vascular. So the location, a mucogingival line, is found on the facial surface of both arches and then the lingual of the mandibular arch. We talked about that. There is no alveolar mucosa on the palate. There's no lining tissue, okay? So that it's going to move to. So it's all going to be attached, okay? So again, they are where the gingiva, the firmly attached gingiva, and the alveolar mucosa meet. So alveolar mucosa, the description is that it's a movable, loosely attached to the underlying bone. It has a smooth, shiny surface. So think of these descriptors as I'm telling you because you need to know what health is, right? So this should be smooth and shiny with non-keratinized thin epithelium. The underlying capillaries can be seen through the epithelium. Then part of this is the frena, okay, or frenum if it's singular. So we have frena or frena, and the frenum or frenum or frenulum. I've also heard all of those said, okay? And what that is it's just a narrow fold of mucous membrane connecting more fixed tissue to the movable mucosa. So one area of that would be if you pull your lip out, your maxillary or mandibular lip out, you're going to see this little tiny muscle, this little tiny tissue. It's like a string that goes from your attached gingiva to your mucosa. Okay, and those can play a big role in recession. So we need to be aware of those and evaluate those during our assessment. There's many of them in the mouth, the maxillary and mandibular anteriors at the midline. Then you're going to see a lingual one, which is what can cause ankyloglossia. Remember the tied tongue, when that frenum attaches from the tip of the tongue to the lingual tissues. And so that is our tongue tied, right? So that's kind of what I want you guys to get out of this slide. And we're going to talk about it a little bit more here as we move on. Okay, you can see in this picture we have a really great, I love this picture. This mouth is so healthy other than this little black triangle between the two central incisors and the mandibular. But please do review that. Excuse me. What I want you to see here, hopefully you guys didn't have your volume up too high, is the crest of this bone. And I'm using black and I'm on number 8 here because remember their right side is our left side. Okay, so this crest of the gingiva is the gingival margin. Okay, and then we can see this line right here. And that's our free gingival groove, okay? And then this in here is our free gingiva, all right? Then this pink stippled area is all of our attached gingiva, okay? And this looks like it's a frenum or frenulum or frena, you know, whatever you want to say. But notice how in the anterior, the papilla comes to a point, okay? And that is healthy. What you want to avoid, I'm going to draw on the distal of 9 here, is having that kind of come here and more blunted. That would be a sign of disease, okay? Okay, I accidentally clicked out of this. So what I want you guys to see here is that there are some frenums that you can see here. So these muscle attachments right here. You can see them back here, here. You can see them down here. So there's lots of frenulums. And just, you know, keep reviewing this. You can't see it too many times. Again, here's our free gingival margin. Make sure you guys know where all of this is. Pause this, quiz yourself. Even print the slide and white out everything and label it, okay? That would be extremely helpful for you to know. So here, notice that the junctional epithelium is on the enamel. So maybe this tooth isn't erupted all the way, or, sometimes it can be on the enamel, sometimes it can be on the cementum. Usually it's going to be on the cementum. Okay, so the gingival sulcus, again, we've already talked about this. It's the space between the free gingiva and the tooth. The boundaries are the inner, which is adjacent to the tooth. Outer is the sulcar epithelium. Then we have the base, which is the coronal margin of the attachment probing depth. Okay, the sulcar epithelium is non-keratinized. Okay, so it's not waterproof. I always think of that, whether it's waterproof or not, right? So remember, fluids can come in and out of that. Depth of the sulcus, average histologic is going to be 0.8 to 2.1 millimeters, and the average clinical probing depth. Notice how these are in purple. Make sure you know those, okay? Average clinical probing depth, 1.3 to 2.7. Of course, when we are probing, we are rounding to a whole number, but you need to know the average clinical probe depth. Then we have gingival crevicular fluid or sulcar fluid, and the amount and composition changes with inflammation. It's going to increase because remember, we don't have a lot to start with when it's healthy. But then it's going to increase because that tissue is being stretched with the inflammation, allowing more fluid out. JE, our junctional epithelium, again, is the attached epithelium, stratified squamous, non-keratinized epithelium with two layers or two basement membranes, one to the connective tissue and one to the tooth. It goes all the way around the tooth, like a cuff. So, you think of the cuff on your sweatshirt or your jacket, how it's tight around the wrist and then it kind of frees up a little. That would be your junctional epithelium. Your cuff would be the junctional epithelium. Okay? The junctional epithelium cells have wide fluid-filled intercellular spaces that contain PMNs and monocytes. They should be in health triangular, widest at the junction, which is going to be 15 to 30 cells, and then it narrows down to just a few cells at the apical end. Okay, so it's going to be thickest at the base of the pocket, and then it's going to just taper down inside the body, right? And the length, total length is going to be 0.25 to 1.35 millimeters. The position is going to be on enamel as the tooth erupts. It's going to migrate towards the CEJ. Full eruption is going to be on cementum, but this will migrate with disease. Okay? The relation of the alveolar crest bone to the attached gingival tissues, the distance between the attached base and the alveolar crest is about 1 to 1.5 millimeters. Okay, so not much. This distance is maintained in disease where it migrates apically as the bone loss occurs. And that's what creates our pocket. Epithelial attachment to tooth surface, we got the hemidesmosomes, right? So acellular to acellular. And the basal lamina of the junctional epithelium. All right, so here's the tooth as it's erupting. You can just watch that attachment as it progresses and then becomes recession at E. All right, the shape of the interdental papilla. If I'm asking you to describe the interdental papilla in health, what are you going to tell me? You're going to tell me that in the anterior it's pointed and pink, and between the posterior teeth is going to be flatter due to the width of the teeth, but that it has two papilla, one on the facial, one on the lingual, and they are connected by the caul. The caul is the depression under the contact, and the center is usually not keratinized. Most perio infections begin at the caul, C-O-L, caul. Interproximal area, the embrasures, you can see type 1, the gingival tissue is going to fill that embrasure space. And then type 2 is going to be slight to moderate recession of the interdental gingiva. And type 3 is going to be extensive, where the papilla is below the CEJ. Here's our caul, and you can see where the contact area is and how that caul just kind of follows that contact area in health. Extent of the attached gingiva is continuous with the oral epithelium of the free gingiva and is covered with keratinized stratified squamous epithelium. The maxillary palatal gingiva is continuous with the palatal mucosa. Therefore, there is no mucogingival junction. The attached gingiva of the mandibular facial and lingual gingiva and the maxillary facial gingiva is demarcated from the alveolar mucosa by the MGJ, the mucogingival junction. That's on the mandibular facial, the mandibular, lingual, and the maxillary facial. And you'll be measuring that, so it's really important that you know that. Attachment is firmly bound to the underlying cementum and the alveolar bone. The shape, it follows the depressions between the eminence of the roots of the teeth. The MGJ appearance is connection between the attached gingiva and the alveolar mucosa. Anterior line is scalloped. Posterior line to the premolars is pretty much straight. You can see a contrast between the pink attached gingiva and the darker reddish pink vascular alveolar mucosa. The location, facial surfaces of all quadrants and lingual of the mandibular arch, none on the palate, right, because it goes to the palatal mucosa. There's no MGJ there. And that just states it again. They really want you to know that, right? It is important because we're going to be measuring how much attachment there is. All right, our alveolar mucosa description, movable. Unlike the attached gingiva is really firm. You can't move it. The alveolar mucosa, you're going to be able to move it. So it's just really loosely attached to the underlying bone. It is smooth and shiny rather than stippled, right? This is non-keratinized. So our attached gingiva is keratinized. Our alveolar mucosa is non-keratinized. It's a very thin epithelium and has underlying vessels that can often be seen. Here again, we're talking about our frena, which is a narrow fold of mucous membrane that passes from a more fixed to a more movable part. It serves to check undue movement, so they're excessive movement. Locations, they're all over the place, but maxillary, mandibular, anterior midline, the lingual, which is under the tongue, and then buccal frena, which can be canine to the premolar area, both maxillary and mandibular. So a tension test is what is used. You do need to know that, so underline it, highlight it, write it down, whatever you need to do. But the tension test is how we locate those. So we're going to kind of pull the lip out, and you're going to move it side to side, create a little tension to check them, okay? Attachment in relation to attached gingiva associated with a mucogingival junction. One attached gingiva is narrow or missing. It may pull on the free gingiva and displace it. So that's where our concern comes in. Our PDL is a fibrous connective tissue that surrounds and attaches the bone to the cementum. This is part of our attachment apparatus, right? We have our bone, our root, and our periodontal ligament. This is composed of cells and extracellular compartment. We have osteoblast, osteoclast, fibroblasts, and epithelial cells and cementoblasts. There's also collagen fiber bundles. Now, fibers insert into the cementum on one side and the alveolar bone on the other side. The Sharpie's fibers, I always think of them as Sharpie's fingers. They're embedding themselves into each of these areas, one on each side. So we have two groups. We have the gingival groups that surround the tooth, and then we have the principal fiber group that surround the root. All right, so here's our gingival fiber groups, and you do need to know these. We have our alveolo-gingival fibers, okay? Alveolo-gingival, bone to gingiva. Dento-gingival fibers, what does that tell you? From the tooth to the gingiva. Then we have circumferential fibers that are going all the way around. They aren't attaching. Notice how there's no dento or alveolo-gingival, nothing. They're circumferential fibers. They are encircling the tooth. Then we have our dentoperiosteal fibers, okay, from the tooth to the periosteum. And then you can just see there where the cementum is on the tooth. All right, so our dentogingival fibers, these are in our free gingiva. The cementum in the cervical region into the free gingiva, these give support to the gingiva. Dentogingival, tooth to gingiva. So cementum in the cervical region into the free gingiva. Alveolo-gingival fibers, they're going to be at the alveolar crest into the free and attached gingiva. These also provide support. Then we have our circumferential fibers, or our circular fibers. Circular meaning it's going around the tooth, but it's not inserting anywhere. This is like a rubber band in there, okay? It's just going around the tooth. And this is to help maintain tooth position. Then we have our dentoperiosteal fibers, and these cervical are attached, the cervical cementum over the alveolar crest to blend with the fibers of the periosteum of the bone, the outer surface of the bone. Then we have our transseptal. Trans meaning across, right? Cervical area of one tooth, then it crosses to an adjacent tooth. So these are found only on the mesial and the distal areas. And these provide resistance to separation of teeth. So think of orthodontics here. Okay, these are being disturbed in orthodontics. All right, so here's a nice picture of our transseptal fibers. Now these are our principal fiber groups, and we have the alveolar crest. All right, we have our horizontal fibers, our oblique fibers, and our apical fibers. All right, apical fibers. These are found at the root of the apex to the adjacent surrounding bone. These resist vertical forces, so biting down, okay? Oblique fibers, the largest and most significant group, these extend from the cementum coronally to the bone. So they're inserting in the cementum and going upward. All right. These resist vertical and unexpected strong forces. These are there to withstand masticatory stress in a vertical direction. Then we have our horizontal fibers. And they extend from the cementum in the middle of each root to the adjacent alveolar bone. These resist the tipping of the tooth. Okay, then we have our alveolar crest fibers. And our alveolar crest fibers go from the alveolar crest, so the top of the bone, to the cementum just below the CEJ. and these resist intrusive forces. Then we have our intraradicular fibers, and these are found only in multi-rooted teeth. So inter, within, right? Radicular, we're looking for, just think of within the roots, okay? Extending from the cementum to the bone in the areas of the furcation. And these are there to resist vertical and lateral forces. So which teeth would these be found on? Well, these would be found on any of the multi-rooted teeth, which include the maxillary first premolar. They could be on the mandibular canine if that's bifurcated. And then all of our molar teeth, right? All right, cementum. The cementum is a thin layer of connective tissue. It covers the tooth from the CEJ down to the apical foramen. Its functions are to seal the tubules of the dentin, of the root dentin, I should say, and provide attachment for the periodontal fiber groups. Characteristics, it's 50 to 200 microns at the apex and 30 to 60 microns at the cervical area. They are vascular and nerve connections, their vascular and nerve connections are missing, therefore they're insensitive. The relationship to enamel and cementum at the cervical area, now 10% of teeth the cementum and the enamel don't meet. So we have exposed dentin, and you can see that in letter A. Then we have edge to edge, okay, where the cementum and the enamel just touch each other very lightly, very quickly, okay? Then we have 60% where the cementum overlaps the enamel. So which of these three are going to have the most sensitivity? That's going to be group A with that exposed dentin, right? All right. Now we have our alveolar bone, and that includes the lamina dura, and that surrounds the tooth socket and the supporting bone. When teeth are lost, the alveolar bone is resorbed. It supports the teeth and provides attachment for the periodontal ligament fibers, so very important. All right, our alveolar bone loss, you can see on these x-rays, and we aren't going to get too much into it here because you guys are going to get a lot of this in radiology. But you can see on these x-rays why this bone has resorbed. One contributing factor, or risk factor, I should say, is all of this calculus, all these white chunks here. This is the tooth, and all this light radio-opaque area is calculus, okay? Okay, so we always say when you're describing gingiva, you want to have the 3 C's, which is color, contour, and consistency. Okay, but the evaluation does include the color, the size, the shape, the consistency, the surface texture, position, the MGJs, and bleeding and exudate. All right, now this is beyond important for you guys, okay, because you're going to have to describe here at Herzing and when you get out into practice, you have to be able to describe what their gingiva looks like, okay? So in health, you're going to see a uniform pink or coral area, varies with pigmentation. You're going to see it snug or tightly adhered to the tooth. The shape is you're going to see nice margins. The papilla is going to be pointed in the front, a little bit flatter in the back. And then you might see a little space or diastema. And then consistency is going to be firm. And surface texture, you're going to have free gingiva with smooth attached gingiva, which is going to be stippled. Then we have position of the gingival margin. You want the margin 1 to 2 millimeters above the CEJ or slightly below the enamel. The position of the junctional epithelium is eruption dependent. So if the tooth is fully erupted, it should be on the cementum. And then the MGJs should be clearly demarcated. All right, changes in disease, clinical appearance. You're going to have to note whether it's acute or chronic. Okay, so acute is going to be more red. Chronic is going to be just a little more fibrous. Okay, and the change is due to inflammation. Now, if it's enlarged and not snug to the tooth, say it's a little spongy in there, we're going to call that edematous or fibrotic. The shape, margins might be rounded rather than pointed or rolled. The papilla could be bulbous, flattened, blunted, or cratered. Inflammatory bulbous with gingival enlargement, cratered is going to be with necrotizing ulcerative gingivitis. Then our consistency. It should be firm, but if we see that it's soft and spongy, we're going to note that there's some edema in there or that it's fibrotic. Then our surface texture is going to be acute, is going to be smooth and shiny. Okay? So red, smooth, and shiny. So start putting these words together. Okay? Chronic is going to be hard and firm, almost kind of leathery. Okay? Then the position of the gingiva at the margin. Is it enlarged or is it receded? And then the position of the junctional epithelium, that's going to be determined with the probe. Is there apical migration of the junctional epithelium? Okay, which is going to allow for recession or more of that clinical crown. And then MGJs, no attached gingiva, or if there's frenum pull. Okay, so lots of things to think about. Make sure you guys understand what these are going to look like, what health looks like, and what disease looks like. Okay, clinical examination, know the extent. Gingival infection versus periodontal infection. Gingival infection is reversible, periodontal isn't. Periodontal indicates permanent damage. Okay, so you can't grow the bone back, permanent damage without surgical means. Okay, so permanent damage would include bone loss, would include attachment loss, but gingival infections or gingivitis is just going to be the inflammation of the gingiva. Okay, so you want to make sure that you measure the gingival tissue changes, that the mucogingival junction. If that junction, remember that's farther down, that's between the attached gingiva and the free gingiva, and the alveolar mucosa. If that's involved, infection's going to spread like crazy because there's so much more room under there. Okay, we're going to look at our probing depths. Bleeding doesn't happen in health, nor does pus or exudate. Okay, so we need to note all of these. Is there furcation involvement? When you're probing in there, can you feel that furcation? Okay, how much dental biofilm is in there? You're going to want to check that mobility by using two dull or blunted instruments. Okay, and then you're going to look at your radiographs also. So this is all going to help you determine whether it's gingival or periodontal. So the recognition of gingival and periodontal infections, signs and symptoms may or may not have specific symptoms, but bleeding is going to be our very first sign. So if a patient has bleeding, we need to look at, is it gingival or is it periodontal? And how, the extent, how much bleeding is in there, okay? Do they have sensitivity to hot and cold and tenderness? Is there malodor in their breath, okay? Do they have a chronic bad taste? Are the teeth loose? All right, these are all signs and symptoms that we need to look at. So remember, who's saying what and where it would go. If the patient's reporting it, what is it? And it goes under what in your notes, of your SOAP notes, okay? I want you guys to really start thinking about where you're going to be putting all of this information. All right, so here's our health. Notice how the gingiva is nice and stippled here. You're going to notice that it's the papilla is pointed. The stippling you can kind of see. I'm going to circle this area here. You can kind of see that orange peel appearance. That is stippled. But then you go over to the right side and you're going to see some marginal erythema, so marginal redness, right? Notice how these embrasures are not filled, okay? This would be a type 2, right? Type 2. So, also notice the alignment of the teeth. Notice that there's a little more crowding and stuff on the maxillary, or on the right side, than there is on the left side. So that could be contributing to it. And we need to figure out how are we going to motivate this patient to take care of their oral health. So I'm guessing if we went in and we probed this area here, I don't know why I just made an upside down triangle, but if we probed, especially, boy, it's really getting red back here, it's going to bleed, okay? And then we have our periodontal disease involvement. You can see that there's some attachment loss. If you look here, this is the CEJ. This is all root surface, so we already know that it is periodontally involved. This measurement looks like it's about a 5 or 6. Also note how the tissue is kind of bluish here. It's got like a bluish hue. That's cyanotic. This person's in a lot of trouble here with their teeth. All right, so health and disease. You can see in the upper picture that the gingival health is looking good, the bone is anchored, and the teeth are firmly in place. Then in the second picture, you can see where there's bacteria here. We have a little bit of calculus kind of irritating the area. That is a risk factor, right? So it's irritating the gums, making them red and tender and swollen, which is then allowing the bacteria to go in and to destroy the bone. Okay, then here in number 3, you can see where that gingiva has really migrated and the attachment has migrated down farther. And look at this, the bone is going down, right? Notice how it's not pointed. Look at this first on the left side. I'm going to draw a little arrow there, but it's not regular, right? It's kind of irregular pattern of the bone on all of those. All right. So the recognition of gingival and periodontal infections and health. In health, we want to see shades of pale or coral pink, varied by complexion and pigmentation. So, not everybody's is pink. The knife-edged gingival margins that adapts closely around the tooth. So I want you just to see how that free gingiva, that gingival crest, okay, of the free gingiva, the gingival margin, is going to be pointed towards the tooth. It's going to be closely adhered to it. It's not going to be rounded, okay? So if it's nice and firmly attached, it's going to be kind of knife-edged, thin there, that's perfect. We're also going to see stippling and firmness and multiple sulcus depth with no bleeding when probing. All right. Now, the causes of tissue changes, biofilm can cause breakdown of the intercellular substances of the sulcar epithelium. So injurious agents can pass into the connective tissue, and that initiates that inflammatory response, right? Inflammatory response means that there is an increased blood flow, which is going to cause more permeability of the capillaries and increased collection of defense cells and tissue fluid. Okay, so that's why we're going to get more of that gingival crevicular fluid in disease. Disease can change the color, the size, the position, the shape, the consistency, the surface texture, bleeding readiness, and exudate production. So there's a lot going on in there. The recognition of gingival and periodontal infections, descriptive terminology. So severity is going to be slight, moderate, or severe. And then we're going to say, is it localized, involving a single tooth or a specific group of teeth? Or is it generalized, where it's involving almost all of the teeth? So you think of bleeding. Is it bleeding on number 5, or is it bleeding throughout? Okay, if it's bleeding on number 5, we're going to say it's generalized. If it's bleeding throughout, if it's bleeding on number 5 only, it's localized. If it's bleeding throughout, then it's generalized. Marginal means that it's confined to the free or marginal gingiva. Okay, so that's going to be more like our gingivitis, right? So marginal inflammation. So in the marginal gingiva. And then papillary means that it's involving the papilla, but not the rest of the free gingiva. So we could say generalized papillary inflammation. Or we could say generalized diffuse bleeding or diffuse exudate, diffuse inflammation, meaning it is everywhere in the free gingiva, in the gingival margin, interproximally, everywhere, okay? The recognition of gingival and periodontal infections, early recognition of tissue changes, detection of changes. Marked is going to be obvious signs and symptoms. But then we have subtle, which is localized early. Tissue may appear healthy still, but there's a fire down below, okay? There is a battle being fought there. And so it requires more skill to notice those areas and those problem areas than it does the really marked, obvious signs. So early recognition and treatment, less complicated, less costly to the patient, and also more successful, which is what we all want, right? We don't want the patient to have to pay $1,600 to have scaling and root planing done. We want to catch it now when it might be a little bit more than they normally are used to, but we're going to catch it early and we don't have to have them come in every 3 months, okay? All right, so let's go into more of our descriptors here. Gingival shape or contour. We're looking at the papilla here. We see blunted papilla where it's just kind of flat across, it's not pointed. Then we see bulbous, which is really inflamed where it's kind of covering part of the enamel of the tooth. Then we have cratered, and cratered is often seen in ulcerative, necrotizing ulcerative gingivitis or periodontal disease. So that's, again, where it's more indented, okay? And then we have rolled, and that looks kind of like a lifesaver, you know, like you throw out a tube, or, you know, even the lifesavers that you eat, right? It's kind of just this round, like you just slipped it over the tooth, and it looks like it's going to save it from the water. And these are also called McCall's festoons. So you could say the tissue is, the marginal tissue is festooned, okay? Then we have V-shaped clefts, and a cleft is just kind of that one little notch in the tissue. And we have the V shape there, which is the Stillman's cleft. And then we have slit-like Stellman's cleft of varying degrees and severity in relation to the mucogingival junction. So how close is it getting to that MGJ? And the MGJ is, is right here. Remember, that's where the tissue is more loosely adhered. So once that gets down to there, then infection is really hard to catch and much more difficult to treat. All right, so then we have our gingival hyperplasia, and this is often drug-related, and you can see this is just excessive growth of the gingiva, okay? You can see there's really not a lot of plaque in there, but you're going to see some bleeding and some inflammation due to gingivitis also because they can't keep it clean. All right, then we have localized recession, which is a single tooth and may show kind of a narrow, wide, deep, or shallow recession. So A is wide and shallow, meaning it's all on the facial surface, but it's not very, it's maybe only a millimeter, okay? And then we have B, which is wide because it's, going across pretty much that whole facial surface. With narrow, but it's deep with narrow attached gingiva. And that means right here, we don't have a lot of attachment before we get to that mucogingival junction. Then we have narrow and deep with missing attached gingiva. There's nothing attaching it here. Okay, so this is a problem. All right, so clinically visible recession of the gingival margin with root surface is apparent to the eye. And then we have the actual recession exposes the root surface as the periodontal attachment migrates along the root. So sometimes what we'll see is recession of the gingival margin with root surface that is apparent to the eye. And then we have the actual recession, which is what is also below that gingival margin. Okay, let's talk a little bit about the gingiva of young children. You do need to examine their gingival tissues. They get gingivitis just like adults do, okay? Especially with diabetes and children being on the rise, type 2 diabetes. We need to really watch this, look for that bleeding and that inflammation. And then mucogingival problems usually does signal the necessity for braces. All right, gingiva after periodontal surgery. This is often referred to as pocket reduction surgery, or the first one I should say is pocket reduction surgery. And the characteristic of normal healthy gingiva takes on a different dimension for the patient who has completed treatment for pockets, bone loss, and other signs of periodontal infection. The junctional epithelium may be apical to the CEJ. After healing, the sulcus depths may be within normal range and no bleeding occurs when probed. With each periodontal maintenance appointment, a thorough, careful examination is necessary to control the factors that may have caused the problem in the first place. We don't want a reoccurrence of the disease, right? Then we have gingival grafting surgery. You guys are going to go a little bit more into depth with this in your perio course. So we're just kind of touching on it here. Depending on the extent or the exact surgery performed, examination shows changes from the initial evaluation. So for example, where the initial examination showed a deficiency in the attached gingiva with a frenal pull, sometimes they'll call that gingival stripping. The mucogingival surgery may have created a new attached gingiva, okay? So they have, the doctor has done a graft there to put attached gingiva in the area or to help the gingiva reattach in that area to prevent further damage. And then we have implant surgeries, and the gingiva around the implant should have the same color and consistency as all the other natural teeth gingiva, okay? The contour of the gingiva will depend on the placement of the implant, but may result in an open embrasure interproximally, like those after pocket reduction surgery. So pocket reduction surgery, they're bringing that gingival tissue down so that the patient, it's at a depth where the patient can clean it, okay? So maybe it was an 8 mm pocket, they're gonna reduce it down to a 5 mm pocket by trimming away the gingiva, smoothing the bone. And so they're gonna bring it down to a 3 mm so the patient can clean it, but then that's gonna open the embrasure space, okay? And so that kind of happens with implants too. They don't always get the papilla that we're looking for. All right, so here's an example after pocket reduction surgery. You can see this looks really nice and healthy. The patient has been obviously taking very good care of it. But you can imagine the difficulty in cleaning these, because as you get further down, you're going to have more of those concavities and convexities to have to work around. So, but it is possible to clean it. And you can see kind of the process of the surgery down below, where before surgery, the bone is kind of rough. They retract it, they clean off the tooth, they smooth the bone down. They may apply a medication, and then they're going to close it up, and then the tissue is going to heal, but you're going to have that recession there, okay? So these are blunted papilla due to surgical means. All right, and then here's gingival grafting. One of the hardest places to graft is the 24 and 25, the two lower central incisors. Very difficult to graft because of the frenum there. Often the frenum needs to be snipped or reduced so that it doesn't come back. All right, and here's implant surgery where they use titanium screws essentially to go into the bone, and sometimes they don't even need to, they can sometimes just puncture the tissue without having to retract that gingiva. So a lot of guided surgeries, you guys will probably talk about that in periodontology, but guided surgeries, they put a mouth guard on that has a hole already drilled that needs to be the angle. So the implant is going to go through there, and that's going to guide them into the correct spot of the bone. And that includes using a CT scan, which a lot of dental offices are now starting to get. So it's very interesting. All right, gingiva after periodontal surgery. Boy, look at how nice and healthy that is. So it varies depending on the type of surgery, but the gingival epithelium may be apical to the CEJ, but we're going to keep it nice and clean. And then these patients are then placed on a 3-month recall, so they're coming in 4 times a year. Sometimes they can go to 4-month after they've maintained that 3-month for a while and things are looking good. The dentist may say, you know what, let's try 4 months, okay? So our documentation, we are going to document, well, first of all, we need to make sure we document the health history in S, right? And then we're going to document our initial charting and descriptive terms to show disease symptoms with information to show the need for actual treatment. So if you don't put that in there and you get audited by an insurance company, all that money can be taken away from the dentist, okay? So it's important that you have all those descriptors and all the documentation stating what happened. And a lot of places now will also ask for radiographs. You also want to individualize or customize the home care instructions and the biofilm scores. We actually put our biofilm scores in A because that is an assessment. There's a number attached to it. So that's put in A, okay? And then the patient's own comments related to health changes, habits, dietary changes, their successes, and then perio maintenance agreement program should be recorded in S. All right, factors to teach the patient, characteristics of what a normal healthy gingiva looks like, the significance of bleeding. Healthy tissue does not bleed. Some people say, I flossed too hard, I brushed too hard. No, healthy tissue does not bleed, okay? Relationship of the findings to any other conditions, special attention, what areas do they need to focus on, and then method of brushing. We want a soft toothbrush. We want we don't want too abrasive of a dentifrice, right? And then pressure applied during brushing can be a factor in gingival recession. And we're gonna get into that. Let's see here. I'm trying to think what semester everybody got their toothbrushes. I don't know, I might have Oral B come in for you guys, do a lunch and learn. Let's talk about that, okay? All right, oral mucosa review. The oral mucosa is the lining of the oral cavity. It is stratified squamous epithelium. It's composed of connective tissue that's covered by stratified squamous epithelium. There are 3 divisions: masticatory, lining, and specialized. Masticatory mucosa covers the gingiva and the hard palate. That's going to be our keratinized, right? It's going to be firmly attached. It's going to be able to withstand chewing. So let's talk about the lining mucosa. Covers the surface of the lips and the cheeks, the floor of the mouth, the underside of the tongue, the soft palate, and the alveolar mucosa. Tissues are not firmly attached to the underlying tissue, meaning that they are movable, and these are not keratinized. Then we have specialized mucosa, and that is what covers the dorsum of the tongue, which is composed of many different papillae. And you can see that in this picture: the circumvallate papilla, the foliate papilla, fungiform, filiform. So make sure you know those 4 types of papilla. All right, so let's talk about those. The filiform are thread-like keratinized elevations that cover the dorsum of the tongue, or the dorsal surface of the tongue, and they are in the highest number, okay? We're going to have more filiform than any others. Then we have our fungiform. Fungi, think of mushroom. Mushroom is a fungi, so we want to associate that with the fungiform papilla. And they're going to be interspersed amongst the filiform papilla on the tip and sides of the tongue. They contain variable numbers of taste buds. So fungiform, you're also going to taste. So think of tasting mushrooms. Then we have a circumvallate papilla, and there are 10 to 14 large round papilla arranged in a V between the body of the tongue and the base. And the taste buds line the walls of the circumvallate papilla. Then we have foliate papilla, and those have vertical grooves on the lateral posterior sides of the tongue. So we'll see those definitely in clinic. And these also contain taste buds. So the ones that don't contain taste buds are the filiform. All right, here is a picture of specialized mucosa. And this is the end of chapter 18. A lot of information, but you stuck with it. Good job.